Hello, my name is Patrick Langley, and welcome to my research prospectus on how does the Mediterranean diet effectively alter cardiovascular disease risk factors, or CVD, versus the control diet, a traditional ketogenic diet, in the specified and interested population of middle-aged obese males between the years of 25 and 65 years old. Cardiovascular disease claims more lives each year than all forms of cancer and chronic lower respiratory disease combined in the year 2017. That accounts for 1 in every 3 deaths when attributing death to cardiovascular diseases. Cardiovascular disease is one of the most common chronic diseases, and it can develop because of previously present morbidities. The use of a Mediterranean ketogenic diet versus a low-carb, high-fat, classical ketogenic diet is utilized for determining its effects on CVD risk factors in middle-aged obese males between the ages of 25 and 65 years old. Some of the CVD-related risk factors include high serum LDL, obesity, and the male gender. Because of this, that is the reasoning for the choice of the population to study. You may be wondering what the variations are between a Mediterranean ketogenic diet and a traditional classical ketogenic diet. The traditional ketogenic diet is usually very low in carbohydrates, high in fat, and moderately of protein. The diet of Mediterranean ketogenic diet typically is 1 glass or 240 milliliters of red wine per day, green vegetables and salads as the main source of carbohydrates, fish as the main source of protein, and greater than or equal to 30 milliliters or 1 tablespoon of virgin olive oil per day as the principal or primary fat source. The general objective of this study is to determine the variations between the Mediterranean ketogenic diet and the traditional low carbohydrate, high fat ketogenic diet on the specified CVD risk factor, high density lipoprotein cholesterol, or HDL cholesterol. In middle-aged obese males between the ages of 25 and 65 years old. In considering the literature review, in a study that looked at HDL cholesterol and CVD risk prevention by Radar and colleagues, found that LDL is a well-known causal factor for CHD. 31% had a decrease in coronary events and a 29% decrease in CHD mortality in those following a ketogenic diet. Increasing HDL levels was also found to be correlated with reduction in major CVD events in patients who have CHD, as well as those with low HDL levels. In another study that looked at the effects of a ketogenic Mediterranean diet with phytoextract supplementation, showed a reduction of BMI, overall weight status, a decrease in CVD risk factors, waist size, and that the participants had good compliance with the diet. Another study looked at the long-term successful weight loss with a combination of a ketogenic diet and a Mediterranean diet for maintaining weight loss. Fluctuations between the ketogenic diet and the Mediterranean diet were observed and also were found useful for weight loss successes long term and the improvement of cardiovascular risk factors. This research thus far shows the need for this current study as it relates to the variations in changes on cardiovascular risk factors, specifically HDL, and the variations of the ketogenic diet, such as the Mediterranean ketogenic diet and the classical ketogenic diet. The research and null hypotheses were found to be as follows. A 90-day Mediterranean ketogenic diet will not change cardiovascular patients' HDL levels more than a classical ketogenic diet. The research hypothesis is a 90-day Mediterranean ketogenic diet will change cardiovascular patients' HDL levels more than a classical ketogenic diet. The quantitative design of this study included continuous interval data of pre and post collection of serum HDL levels in participants of the two different types of ketogenic diets. Descriptive statistics will simply show height, weight, and BMI for calculation and qualification of the study. Statistical analysis will look at the variations in means of the different HDL levels and how they change between participants, as well as the correlation coefficient. Duke University Medical Center cardiologists and their patient network will be utilized in determining participants. They will be given the right to choose between a general CVD treatment and the intervention or the study treatment. In looking at the limitations of the study design, it was not considered that statin medication would affect an increase in HDL cholesterol in those participants who have diagnosis of CVD and are treated with statins. As well, serum ketone levels was not taken